Psychosis who lived in a mental hospital, in an asylum. And my girlfriend was an occupational therapist, a very enthusiastic occupational therapist in this mental hospital. And one of her colleagues was getting married. So my girlfriend decided she would take a group of the chronic patients to the wedding. So these are all the patients from who some of them had been in hospital for 10 or 20 years. And these are all the ladies getting ready for the wedding. You can see, if you look at their hands, you can see that they all have a pill rolling movements with the thumb opposed to the fingers, because they're on a common side effect of too much antipsychotics, too much blockade. You can see the way their fingers are clasped. Anyway, they all went to the wedding. The bride's mother was very worried as to whether they would behave well, but this was a Scottish wedding. The patients behaved much better than the rest of the guests, some of whom got drunk and caused some trouble, but the patients behaved very well. But I show this picture because after that, they went back to the chronic hospital and stayed there for years. So schizophrenia is often described as an enigma in textbooks. This is not true. There have been major advances in our understanding of the genetic and environmental causes of the illness. The biggest advances have been in genetics and epidemiology, and also with neuroimaging, particularly molecular neuroimaging. We've elucidated some of the underlying mechanisms, and we've clarified the range of outcomes in terms of the good and bad outcomes of patients. So we have learned a very great deal. Some of you will know who Dolce and Gabbana are. Half of the audience perhaps will know who Dolce and Gabbana are. Does our chairman know who Dolce and Gabbana are, Alan? Who are they?
It's an Italian fashion brand.
And where do they come from?
I think they probably, no, just guessing, I think they probably come from Sicily.
Yes, so they do, yes. So my wife is from Sicily, so that was a good guess. In fact, her grandfather, he got his suits from Dolce's grandfather. So is anybody wearing Dolce and Gabbana? Any ladies wearing Dolce and Gabbana? At the moment, no. Yes? You have Dolce and Gabbana, but not today. Maybe this evening. Anyway, this is what you should be wearing this Christmas, ladies. And this is what gentlemen, Alan, this is what you should be wearing this Christmas. So I'm showing you this because their slogan is D&G. And what you need to know about the biology of schizophrenia is D&G, dopamine and genes, not Dolce and Gabbana. So I'll spend a little time on both. So this is a study which has been replicated many times, that if you inject radio-labeled dopa into a person with schizophrenia, it's concentrated in the striatum, and people with acute psychosis have an excess of dopamine synthesis in the striatum, in the associative striatum particularly, not the ventral striatum where drug abuse is the pathology. And so you can see too much dopamine in schizophrenia acutely. What about mania? Do you think people with mania will show the same excess of dopamine or not? Very difficult to do a study because you have to get manic patients and persuade them to lie in a PET scanner for 45 minutes. Not many manic patients will do that. And you also have to persuade the people who run the scanner to let the patients go in because they're worried the patients will break the machine. So this was a heroic study, and it took 5 years, but Dr. Johar managed to get patients, manic patients with bipolar illness, they showed the same excess of dopamine synthesis in the striatum. So this seems to be the common pathway to psychosis in very many patients. Not all psychotic patients, but it seems to be most of them. So we know that the excess, we used to think the abnormality was in the receptor, but the abnormality is mostly in the presynaptic neuron. Too much synthesis, too much release, and the dopamine goes across and hits the receptor. And this causes psychosis. And of course, what we do, many of us spend our lives doing this, we try and throw D2 blockers to block the receptor. We cannot do anything about the primary problem. The primary problem is not in the receptor. The primary problem is in the presynaptic neuron. So this is like giving pain for a headache. Excuse me, not giving pain for a headache, giving aspirin for a headache, aspirin or paracetamol for a headache. It doesn't touch the cause of the headache or the pain. It just blocks a downstream effect. So this is what we do, and this is relatively effective. So why should, we've known about dopamine for many, many years. Why should dopamine dysfunction cause psychosis? It's a long distance. Why should you develop particularly bizarre ideas and perceptions if you have too much dopamine? Well, Mark Laruelle coined this term, that dopamine is the wind of psychotic fire. So abnormal dopamine causes abnormal learning, and this is how the psychosis develops. Because dopamine is essential for the normal identification of important stimuli which should engage our attention. We're always bombarded by lots and lots of stimuli, and we have to decide what to pay attention to. Now, say I don't know if you read in the news or saw on television today that someone in California has won a lottery ticket worth $2 billion, but has not yet claimed this ticket. So presumably this person, man or lady, will go home, will look through the tickets, will find out they have the right number. They will release dopamine. This dopamine grabs your attention for good things, but also for bad things. If this evening you put on the television and you discover that Vladimir Putin has decided to use nuclear weapons in Ukraine, you will also release dopamine. You'll be frightened, but again, it will grab your attention. This is important. Pay attention. So this is one of the things that dopamine does. But when people are acutely psychotic, there's excessively releasing dopamine in the associative striatum. And this heightened striatal dopamine transmission leads to the aberrant assignment of salience, of importance to external and internal stimuli. So all sorts of things that are of no significance seem to become significant. How many red cars did you pass on the way to the hotel? Any idea? No, because it's not significant. But if you're releasing dopamine, you know that red means danger. So you notice, oh, there's a red car, another red car, another red car. Are they following me? You notice that a person that you know looked at you in a slightly strange way. Why are they looking at me in that way? I think they were communicating with somebody behind me, and they're in league against me. So you begin to see too much meaning in everyday events, both external events and also internal events. If you're thinking something at the same time as you see something that suddenly becomes salient, you may put the two together. So this results in attention to irrelevant stimuli and inappropriate learning, and this leads on to the positive symptoms, but it also causes you not to pay attention to important stimuli. You're paying attention to all sorts of nonsense, but you miss important stimuli. Maybe this is what has happened to the person who has not claimed the $2 billion, that they've got too much salience, they're paying attention to all sorts of other things, and they haven't gone to look up their number. But the lack of attention to important stimuli results in lack of motivation and lack of action. So then the delusions arise from the abnormal salience. Why are all these strange things happening? Why are they happening to me? Is it because I'm tremendously important, or is it because they're all against me and conspiring against me? And this is a very old quotation from McGee and Chapman in 1961, who described very beautifully the experience of people with acute psychosis and the loss of ability to screen out irrelevant stimuli. "My thoughts are all jumbled up," said a patient. "Things are coming in too fast. I lose my grip and I get lost attending to everything at once. And as a result, I do not attend to anything." So as you listen to me, hopefully you're trying to listen to me. You're not thinking about how uncomfortable the seat is, or how the lady in front of you is fidgeting about, or what a nice haircut the young man sitting opposite you has. You should not be paying attention to these things. You should be paying attention to the important event. At least I think the important event, me speaking. And this, of course, the abnormal learning can lead to the development of delusional thinking, because meaningful connections are created between temporary coincident external impressions or perceptions with thoughts that happen to be present, or events or recollections that are happening to occur in consciousness at the same time. So you can connect, you can see there's a lady coming in quite late and sitting down. Why is she coming in late? She has been outside talking to my friend, and they're in league together to do something bad to me. So you read too much significance into things. And this is a quote from David Hemsley in 1987. So we can postulate that the person with psychosis is a person who has a predisposition to a sensitized dopamine system, and then some acute stress comes along, and stress releases dopamine, we know that, or drug abuse releases dopamine, and this results in an excess dopamine release. And this results in the aberrant processing of stimuli. Oops, this lady is leaving again, so she's going back out to talk to her friend in order to arrange something bad to happen to me. Or maybe she was just bored. Anyway, there is aberrant salience, and many people with psychosis have had adverse events in their childhood, or they've had discrimination or bullying, or something bad has happened to them. So this may result in biased cognitive schema. So they learn that when nasty things happen, somebody is causing them to happen to you, because that has been their experience. So even when nobody is behind the aberrant salience that they're experiencing, they may interpret this in a paranoid way. So they interpret the events or their experiences in a paranoid way and develop psychosis. But once you develop psychosis, you develop all sorts of worrying ideas. You think the man down the road is trying to influence your brain, that the television is speaking to you. Your parents are in league with the doctors and they're going to try and poison you. So this is very stressful. So the psychosis itself causes more stress, which causes more dopamine release, which causes more paranoia, which causes more psychosis. Now, I don't know what happens in Turkey when somebody is acutely psychotic, but in London, when somebody is acutely psychotic, they may threaten the neighbours with a knife. They may shout at the neighbours phone the police. The police come along and the police phone for a psychiatrist. So somebody like me goes to the house and we try, and the man is barricaded in the house. Does this happen in Turkey? People lock themselves in a house and they won't come out. And do you have to go and talk with them? You just leave them? I see. So the police bring them. So, well, that's not so bad. That won't cause any stress. Poof. So if you're grabbed by the police and the police come and take you to the psychiatric hospital, whoof, your dopamine certainly goes up. And you get to the hospital, and then in the hospital they meet a nice doctor or a nice nurse who says, oh, I'm sorry you're back in the hospital again. We'll give you some medicine to calm you down. We'll give you a little injection. No, not an injection. An injection's going to kill me. I know you're going to poison me. So this releases more dopamine, which causes you to go more psychotic. So you get into a vicious circle. So we have to do something to try and stop that so we can reduce the stress or remove the drug abuse or remove the drugs. We can block dopamine with a D2 blocker. We can use CBT to try and get people to interpret their experience. I mean, you have to be very patient and careful about this, because you don't want to argue with patients. You don't want to say, this is nonsense, these beliefs. You have to say, well, is it possible there could be another explanation for these experiences you're having? And then you can perhaps discuss the adversities that they have had in the past. And there's also new psychological therapies like avatar therapy we could discuss in the discussion later on. So in the majority of cases, this is successful. Something like 85% of people with their first episode of psychosis, you can get rid of the positive psychotic symptoms. And we have done a study. I'm sure I always like to say, when professors say to you, we have done a study, they mean somebody else has done a study. A junior doctor or a PhD student, they've done the work, and we boss them about and tell them what to do. So in this case, it was Craig Morgan and Paula Dazan, both of whom actually have now become very senior themselves. But this was taking about 400 patients with their first episode of psychosis and following them up for 10 years. And we were surprised that at 10 years, 40% of those with a diagnosis of schizophrenia had had no psychotic symptoms for 2 years. So 40% had no psychotic symptoms for 2 years. We were quite surprised by this, because sometimes, particularly drug companies, say this is a lifelong illness. You're going to be schizophrenic forever. It's not true. Some people get better. And 19% of people with schizophrenia had had no psychotic symptoms for 2 years and were not taking antipsychotics. So the other 20% or so were taking antipsychotics, but they had no symptoms. I have hypertension. Well, I don't have hypertension. I take a hypotensive, so I don't have it. So I'm fine. And it's the same with people who are taking antipsychotics. If they're fine, they're not having psychotic symptoms. So the outcome is much better than we tend to think it is. Psychiatrists believed Krepelin, who said it's a deteriorating illness. And of course, we tend to see the people who do worse. If you see somebody in their first episode and they do very well, they don't come back to see you in 5 years and say, oh, doctor, I thought I would come to your outpatient clinic just to tell you I've been absolutely well for the last 3 years. They disappear into the community, so you never see them. You only see the people who do badly. Now, it's not just our study, but 3 other studies have come to similar conclusions. 20% of people can come off antipsychotics and do well, and another 20% will do well continuing on antipsychotics, hopefully a relatively small dose. But there is a problem in that not everybody does well. So, as I said, the antipsychotics can normalize the dopamine dysfunction and the abnormal reward learning, which causes the delusions and the hallucinations in the first place. But antipsychotics cannot normalize previously learned beliefs. I'm sure you've all met people who said, the CIA are no longer, do people get paranoid about the CIA in Turkey? A little, yes? So, yes, yes, everywhere people get paranoid about the CIA. But sometimes people will say to you, after treatment, the CIA have stopped bothering me. They're not causing me any trouble, but I know they were 3 months or 6 months ago, they were persecuting me. So they learned 3 months, they had the aberrant dopamine signaling 3 months ago that caused the development of delusional beliefs. They're no longer having the aberrant dopaminergic signaling. They're no longer experiencing abnormal salience. They think the CIA have stopped, but they don't unlearn what they learned in the past. It's very difficult to change your mind about something. I'm not sure, I don't know enough about Turkish football, but do Turkish men change the football team that they support? Or do they tend to support the same football team forever? They don't change. No, from about age 5, you decide which team, and it may be a rubbish team. Or even where I work in London, some people believe every 4 years that England are going to win the World Cup. This is a delusional belief, or it's an overvalued belief. But it's very difficult to persuade them that this is not true, and it will be won by Scotland. I mean, people often have, in international disputes, people often have paranoid ideas about their opponents. For example, the dispute between the Islamists, the fundamental Islamists and the West is to some extent a paranoid belief on either side, that the West is paranoid about Islamists and Islamists are paranoid about the West. It would not do any good to give them antipsychotics. It wouldn't, I mean, politicians have bizarre, strange beliefs. It would not help them to give them antipsychotics. And similarly, antipsychotics will not change the beliefs that people developed when they had abnormal dopamine dysfunction. So this is something that we need to know. But if striatal dysfunction is not normalized at the beginning of an illness, the stage may be set for a potential vicious cycle in which misinformation becomes more prominent and it almost takes over, colonizes the mind. For example, you begin to believe that you're likely to hear voices. And I have a patient who I've been seeing for many years whose voices are stimulated by noise. So for example, when her fridge starts buzzing, or when an airplane crosses over, she hears the buzzing, or the droning of the airplane, but gradually it turns into a voice. The reason for this is that she has such an intense prior belief that she's going to hear voices in the noise, that her prior belief overwhelms the actual stimuli which is coming in. So this is the notion of excessive priors will actually cause you to hallucinate. It's a view that your cortical beliefs can actually have subcortical consequences. And so eventually, although the abnormality starts off in the striatum, eventually these beliefs get hardwired into the cortex. So although it's nothing to do with dopamine any longer, they're stuck there, that people have developed these concrete ideas. So the hallucinations and the delusions may persist even in the absence of dopamine dysfunction. And because there's no dopamine dysfunction, they will not respond to antipsychotics. CBT may be more important. You need to do cognitive work to get rid of an abnormal belief. You have to work with the patient. You have to, there's no use arguing with your friend who believes in the opposite football team to you. Instead of telling him that his football team are rubbish, you have to discuss with him quite rationally and carefully the possibilities that they may not win the World Cup. So it involves cognitive work to get rid of abnormal ideas. I had a PhD student called Arsimi Demjaha who worked with Oliver House looking at people with treatment-resistant schizophrenia. Remember when I showed that people with acute schizophrenia have an excess of dopamine, but people with treatment-resistant schizophrenia, they don't have an excess of dopamine. So again, this is the striatal dopamine signal. Here are healthy volunteers. Here are responders. So people who have too much dopamine, you block the dopamine, they tend to get better. People who are treatment-resistant, they don't have an abnormality of dopamine. So the more dopamine blockers you give them, you just cause more side effects. It doesn't help them at all. And sadly, that's what tends to happen. When people don't respond to an antipsychotic, psychiatrists tend to double the dose, and if they still don't respond, they treble the dose. So they get a lot of side effects, but they still don't respond. So this is because the dopamine dysfunction is only during the acute phase or usually during the acute phase of psychosis. Well, that's enough for dopamine. By the way, I'm very happy if people would like to ask a question or argue as we go along, because I know what I'm going to say. I have seen the slides before. So it would be more interesting to me if you'd like to ask a question or argue. So this, thank you. A lady would like, I hope it's a nice question after me inviting you.
Yeah, I wasn't sure whether I should wait till the end.
No.
So you said that people can't unlearn what you learned. So if you have an idea during a psychotic episode, even if you went into remission, you will still hold that belief that you gave the example of CIA. Yeah.
Yes. No, you're correct, and of course I'm exaggerating. You can unlearn, but it's quite difficult.
No, I mean in the context of psychosis, because sometimes we have patients. They were saying that, yeah, I was confused at the time. I don't believe in those things. You know, are they lying or? No. I'm exaggerating.
Okay. Many patients, you're absolutely correct. Many patients, when they're no longer bombarded by the excessive striatal dopamine, they're no longer having abnormal perceptions, they look back on it and they develop insight. Okay. So you're absolutely correct. But there are these ones who never regain insight, or they may. Yeah. Excuse me. There are those who say the CIA are still after me, but there are those who say the CIA have stopped. So I've stopped. So it's a very good point that you're raising. That some people develop the insight spontaneously. What we can do with cognitive approaches are talking. This is what we do all the time, talking to our patients, isn't it? To say, is it possible that you were very stressed at the time, and maybe is it possible that the stress caused you to be a bit anxious, and that maybe you might have misunderstood something? And this is what good psychiatrists do. Okay.
Okay, thanks.
Yeah. You need to run. Quick. No, come on, quick, 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 quick.
Very stimulating presentation. I guess you will talk about my questions because I think this slide is about the glutamatergic dysfunction in psychosis, in genetics. My question is about, do you think all the psychoses are responsible with dopaminergic dysfunction? Some glutamatergic, also there are some evidence, and also there is a medicine, pimavanserin, working only on serotonergic system and good working with psychosis in Parkinson's disease. My question is, if some patients with psychosis, the main mechanism is not related to dopaminergic system, and when we give them antipsychotics working on antidopaminergic regulation and long time using, what is the effect of this long use of antipsychotics?
So it's another very good question that it does seem to be that there is a minority of patients who don't show the dopaminergic abnormality. Certainly the treatment-resistant patients, and the question is, have they developed did they have dopaminergic abnormality at the beginning of the illness and did it disappear? There are also some studies at the early onset which do not show the dopaminergic abnormality. So one suggestion is that there is a glutamatergic type of, that there is a dopaminergic type of psychosis, which is the common one, and there may be a glutamatergic one. And some of you will have heard James Stone talk about the role of glutamate. Sadly, the various drug companies have tried. Roche, for example, had spent $1 billion on developing a glutamate drug called bitopertin, and it failed. Lilly also, as James pointed out, had a glutamatergic drug which failed. But of course, glutamate and GABA are involved in controlling dopamine. But it may be that, but you're correct, it may be that, that there is, that it's not all dopaminergic. So I think we must accept that the majority of people, there is the dopaminergic abnormality, but maybe there is a minority which is not. But we haven't really elucidated exactly what that is. The question of the effects of giving antipsychotic. Well, I think you all know the effects of giving high doses of antipsychotics. That it's the same in people who have a dopaminergic abnormality or the people who don't have a dopaminergic abnormality. There is obesity, metabolic syndrome, hypertension, and many physical abnormalities. So we have to be I think we have to be much more cautious about the use of antipsychotics in the longer term. I'm sure many of you are familiar with meeting a patient at age 18, and it's a pretty young lady or a handsome young man, and then they're psychotic, and for some reason they go off and they're treated by a colleague or another clinical team. And 5 years later, as you're going to work, a big fat person comes up and says, "Hello, doctor, do you remember me?" And you have no idea who it is. And it was that handsome young man or pretty young lady who has put on 10, 20 kilos. And so I think we always have to think, we are focused on getting rid of hallucinations and delusions, but would you like to put on, if you had hallucinations, would you rather have some minimal hallucinations, or would you rather put on 20 kilos? It's not an easy decision. How many people would prefer to put on the 20 kilos? A lady as well. But it's not such an easy decision. So anyway, as I said, let's go on to genetics. So this is the most important slide in biological psychiatry. And this is what's called, I think, are you familiar with Manhattan plots? So this is called a Manhattan plot because it's a bit like, supposed to be a bit like the skyline of Manhattan. And along here, you can see all the different chromosomes. And up here, you can see the significance in relation to schizophrenia. So this is a huge study, 74,000 patients with schizophrenia and 110,000 controls. So so many different, maybe some colleagues here were involved in this study, collecting samples, doing a GWAS, genome-wide association study, getting the results and sending them off to Harvard. So in Harvard, they put them all together, and when they did an analysis, they found 263 sites on the genome which differed at one single nucleotide base. So there was a tiny variation between the patients with schizophrenia and the controls at 263 different places. So schizophrenia is not caused by a single gene or 2 or 3 genes. It's like height or intelligence or asthma. It's caused by a whole range of hundreds, if not thousands, of tiny little genes. So for example, if you are carrying the risk variant here, instead of having a 1% risk of developing schizophrenia, your risk might be 1.16%. So you will only, the liability depends on having quite a lot of these susceptibility genes, which of course we all have, because we all have some of these genes because they are genes involved in normal brain function. So if anybody invites you to participate in a molecular genetic study, it's a great thing to do. You'll collect so many cases and you send the DNA off to the lab, and then the results go off to Harvard, and 2 or 3 years later you get your name on a paper in Nature. It's a great thing, so we accept it. So for example, I am a co-author of this paper, and so are all these other people. It goes on for several pages. There are 450 authors of this paper. Can you see the most important author? That's me. I don't know what all these other people were doing. No, I guess they were collecting samples like me. But it's been a wonderful collaboration and shows the benefit of the collaboration. Actually, the gentleman who was coordinating the study said it was much more difficult. The journal demanded the emails of every author. He said it was more difficult getting everybody to send their emails than it was actually getting the DNA in the first place. So anyway, here it is again, and you might have thought to yourself, why is there this big skyscraper in the middle of chromosome 6? This is the peak, and this has come out repeatedly in chromosome 6. And the reason for that seems to be that it's in part due to the presence of different alleles. You know how you get 2 alleles at a single site, of a protein called complement, C4a. And what does this do? Well, it's involved in eliminating pathogens. So it stimulates microglia to get rid of viruses and other pathogens. But it also has another function, that during adolescence, it's involved in eradicating, involved in stimulating or tagging certain synapses to be eliminated by the microglia. So as you know, we all tend to lose synapses as our brains get streamlined in adolescence. And it's complement which is involved in this. And this finding is compatible with the idea which was put forward by Macheri Keshavan, who will be speaking, I think, tomorrow, and he suggested that there may be excessive pruning of synapses during adolescence in some patients with schizophrenia. So maybe some patients have this abnormality on chromosome 6, which causes their microglia to devour too many synapses and causes the deterioration in function before the onset of psychosis. You'll be relieved to know that our friend, the dopamine receptor, the dopamine receptor gene is here on chromosome 11. So many of us, of course, spend our lives trying to block the effects of this gene. So that's reassuring. Another important thing that has come out of this paper is that schizophrenia is a brain disease. Sometimes colleagues write papers and they say that people with schizophrenia are very obese and have lots of metabolic abnormalities. So schizophrenia must be a whole body disease. Actually, we've been doing a study in India and Nigeria, and people with schizophrenia there are not obese. They are malnourished. They have anemia, and if anything, they are more likely to starve. So there's nothing intrinsic about the obesity in people with schizophrenia. But what you can see here is the findings from 2011, 2014, and 2021. I'm not sure how well you can see this, but here, this is all these genes are expressed in the brain. They're not expressed. You'll be pleased to know that schizophrenia genes are not expressed in the fats or the prostate or the vagina or the esophagus. So the genes are expressed in the brain, and particularly in neurons rather than astrocytes. Particularly genes involved in neurodevelopment, and also genes there's a high expression in excitatory glutamatergic neurons in the cortex and hippocampus, and also inhibitory neurons involving GABA. So GABA genes, glutamate genes, which are involved in the control of dopamine, as well as calcium channel genes. And you remember that calcium channel genes are also involved in bipolar disorder. And it's therefore not surprising that there is a huge overlap between schizophrenia genes and other psychiatric disorders and traits. So this is the correlation between the genes found to predispose to schizophrenia and the genes found to predispose to other psychiatric disorders. They overlap to a huge extent. The genes for schizophrenia and bipolar disorder, 3/4 of them are overlapping. So many of them are the same, except genes involved in neurodevelopment tend to be more confined to schizophrenia. But you can see also about 1/3 of the genes for schizophrenia are involved in depression and OCD, anxiety, even ADHD and anorexia. So there's a huge overlap, and also with certain traits. You can see that the genes which predispose to schizophrenia also predispose to people being a little less intelligent. What is the average intelligence of an Englishman? Oh, this is difficult, isn't it? 85? 90? 95? Anybody like to? 120? 100? You haven't met many Englishmen. No. As you correctly point out, that IQ is standardized so that the mean is always 100. Wherever it is in Turkey or New Zealand, the mean IQ is 100. But the mean IQ of people who will develop schizophrenia is in England and in New Zealand is 95. Some very brilliant people can develop a schizophrenia, like John Nash in The Beautiful Mind. But there is a tendency for people who were less clever to develop psychosis. So this is consistently, the IQ is a little lower because neurodevelopmental genes are involved in the illness. But the reason for the overlap, the reason we have such difficulty distinguishing between schizophrenia and bipolar disorder is because they share genetic predisposition and the propensity to synthesize excess striatal dopamine. It's not because we are stupid, bad clinicians that we can't distinguish between the illnesses, because there's so much overlap. I remember listening to one of my junior colleagues telling me, presenting at our ward round, about a patient who had had 8 admissions to hospital. And on 4 occasions, the patients had been diagnosed as having schizophrenia, and 2 occasions had been diagnosed as having bipolar disorder, and on 2 occasions as schizoaffective. And I said to my junior colleague, it's absolutely clear that this man has bipolar disorder. Who were these other psychiatrists that said he had schizophrenia, or I shouldn't have asked this, who said he had schizophrenia or schizoaffective disorder? And the junior doctor's mouth began to twitch a little. And he said, I'm afraid, Professor Murray, you were one of these doctors who said he had schizophrenia in the past. So sometimes we call, the presentation can look like schizophrenia, sometimes it can look like bipolar disorder, because the two merge together. Yes, sure. Do we get we get a microphone?
There are some reports, especially from Japan, that claim that some disorders starting as bipolar illness evolve into schizophrenia later on. Some authors claim that there is a continuum between bipolar illness and schizophrenia. So what is your idea, what's your comment about that?
No, I'm sure it's true. I think there are many ways to psychosis, and one of them is through bipolar illness. I think you've seen, I'm sure you've seen this. The first presentation somebody presents, euphoric, elated, slightly paranoid, but not very paranoid. If they do well, they do not progress. But if they come back several times, they begin to become more deluded and more paranoid, and eventually they may begin to hallucinate. And at this point, we think they've changed from bipolar to schizophrenia, but they just moved a little bit along this continuum. So I'm one of those who think there is no discrete boundary between bipolar illness and, so I would agree with the Japanese colleagues that you can. I don't think people go for so much from schizophrenia to bipolar, but certainly people from depressive psychosis or if Alan, who's looking after bipolar patients, if unusually he treats them badly and they don't get better, then they might come to us, and then we would think, was it schizophrenia? No, it's bipolar disorder presenting with a schizophrenic picture. At least that would be my view. Yes? Yeah.
So clearly there is an overlap between schizophrenia and bipolar, and there's very interesting information from the family pedigrees in Canada suggesting that the people with bipolar disorder who don't respond to lithium are the ones who have an excess of relatives with schizophrenia. And it's also been confirmed in some of the genetic studies by Thomas Schutze and colleagues that the people with bipolar disorder who don't respond to lithium have a higher polygenic risk score. So I think actually it's very illustrative to apply this schizophrenia polygenic risk score to people with bipolar, potentially. I mean, I know it's not quite a clinical tool, but potentially it may be it someday. And the key thing is that the increased amount of schizophrenia weighting seems to be related with non-response, seems to be associated with non-response to lithium.
Yes, I agree totally with that. So for many years, I remember even when I was young, Paul Groff used to go on about how people who responded to there was a genetic trait to respond to lithium. And I agree with that. And we and others have done studies which showed that if you have a bipolar disorder without psychotic symptoms, you have a lower polygenic risk score for schizophrenia. But if you have some psychotic symptoms or you look a bit schizoaffective, then the polygenic risk score for schizophrenia goes up. So I agree with that. Well, here is this question. Is the polygenic risk score useful in psychiatry? And this is by Murray. This is not me. This is actually my son, who is a psychiatrist in Cambridge. I can't resist telling you that the nicest, I mean, Alan's been very nice in introducing me here, but the nicest introduction I ever had was when I went to Cambridge, and the chairman said, well, ladies and gentlemen, tonight, I'm sure you're all familiar with the wonderful research of Dr. Murray. This is his dad. Which is very nice. So he has been interested in, can you actually use the polygenic risk score in psychiatry? And it's at the beginning. You can't go out in the community and yet say that you're going to develop psychosis. But you can estimate anybody's liability, as Alan was saying, anybody's liability to schizophrenia by weighting together all their single nucleotide polymorphisms. So you take all these little skyscrapers and you add them up and you weight them depending on how big they are, and you get a polygenic risk score. Has anybody sent their DNA off to 23andMe or any Ancestry? Anybody sent off their DNA to find out what genes you carry, if you carry any genes for Alzheimer's disease or heart disease? Nobody has done this? Not at all. Alan, you done it?
Did it twice, and they told me it was unreadable, possibly because it wasn't human DNA, is what they said. So,
They said it was unreadable.
yeah, it was
Gosh.
unreadable.
Wow,
So,
he's an alien. But I did this, and I can tell. What would I be worried about having genes for? What would I be worried about? Am I worried about having genes for schizophrenia? No, my normal personality, I'm not going to develop schizophrenia. No, my age, I'm not going to develop schizophrenia. I would be worried about Alzheimer's disease. I don't have any genes for Alzheimer's. I don't have the ApoE variant that causes. I wouldn't tell you this if I did. What else? Parkinson's disease. I don't have genes for Parkinson's disease. What else might I be worried about? Cancer? Yeah, cancer's more difficult genetically. I was worried I might have some English genes. But fortunately, my genes are mostly Scandinavian. A lady over here would like, have you sent your DNA off?
Türkçe, evet. Okay. No.
Oops, excuse me.
Yeah, can you hear me now? Hello, can you hear me? Can you hear me now? Can you hear me, sir? Can you hear me, sir? Can you hear me? Can you hear me, sir? Can you hear me, sir? Salona verdiler.
Hazır mı? Başlayabilir miyim?
The interpreter's gone to sleep.
We are here, sir. We are here. Can you hear me, sir? Can you hear me?
Okay.
Thank you very much for a wonderful presentation. I have two questions. In natural-born blind people, they say that there is a risk for Alzheimer's, and I'm just curious about So about the time and regulation disorder in schizophrenia, especially for those who are dressed up. So can we check other biomarkers except for genetical ones, like the cortisol system in the pre-psychotic ones? Maybe we have a cure chance, the chance to cure. So in the pre-treatment, would it be much more effective?
Can we have a consensus? What did the lady say? Run, run.
Yeah, she thanked you and asked 2 questions. And the first one is about, there are reports that people with congenital blindness are less likely to develop schizophrenia. What are your views on that?
I think it is true, but I've not dealt with blind people. As I understand it, people who are congenitally deaf, they do hallucinate, but they hallucinate with hand signals. So instead of hearing voices, they see people using hand signals.
I think this,
But I don't know about blindness.
I think the second question she asked whether there could be some sort of problems with thermoregulation of schizophrenic patients. Like some schizophrenic patients, they wear very layered clothes, even in the summer. So could there be some other pathways in schizophrenic etiology, like cortisol or anything to do with thermoregulation?
Very good question. And I think people with hearing difficulties certainly are more likely to become paranoid. If you're in a country which you do not understand, like me being in Turkey, if I lived here for a little while, I might misunderstand you and become paranoid. It's easier to become paranoid when you don't understand, if you have a hearing problem, for example. And certainly, young men who take steroids to build up their muscles, they can go psychotic. My last slide shows the answer to your question. We will come back to it. So this is a study by Dr. Vassos, swimming about the Mediterranean. He is Greek, and he has shown, this is the distribution of the polygenic risk score. So there are some people who have hardly any polygenes for schizophrenia. So they're trusting, they're open, they're non-paranoid. But that is not sensible in life. You have to be a little suspicious of people, that if you're not careful, you may get your money stolen or your house broken into. So it's good to have a little bit of caution and be in the middle somewhere here. But if you have too much polygenes for schizophrenia, you're more likely to develop schizophrenia. So if you're in the top 10%, you're 16 times more likely to develop schizophrenia than if you're in the bottom 10%. So we have always tended to think that in the past that schizophrenia was a discrete category, that there were normal people and then there were mad people, schizophrenic people. Like there are people with normal people and people with a broken leg. You either have a broken leg or you don't have a broken leg. Or you are normal or you have malaria or measles or some other discrete illness. And we tended to think this was the case, and that there were these psychotic people, they can't think properly, they have bizarre experiences, bizarre beliefs, they can't plan for the future, they have poor relationships with other people. And then, on the other hand, there are normal people. And normal people are entirely normal and predictable. Is Trump psychotic? No, he's very strange though. I worried last year, I thought this joke has gone out of fashion. This is too late to show this joke, but he's coming back. The Trump is coming back, so it's still a good joke to have. So what we have learned is that abnormal people with psychosis are only abnormal in a small way. Most of the things they're entirely rational about. They can look after most of them can look after themselves. They're sensible, except for their delusions. And on the other hand, normal people are not as normal as we think. Many normal people have strange beliefs. Is astrology common in Turkey? Do people look at their horoscope? Shall I ask it? How many men looked at their horoscope this morning? How many ladies looked at their horoscope? I mean, looking at one's horoscope is ridiculous and non-scientific, but people still do it because they have a little belief. Today I will meet a handsome stranger. Could be true? No. But it's ridiculous, isn't it? But normal people have strange beliefs. Now we know there are hundreds of susceptibility genes. This is not compatible with the discrete illness of schizophrenia. It's more compatible with the idea of a continuum of liability. So a normal distribution of liability, genetic liability and environmental liability. Most people are in the middle here. As you go up this way, you may develop the odd, a paranoid idea about your neighbors. You don't need to see a psychiatrist, but you have some minor psychotic symptoms. A little farther down, you might get referred by a doctor to a prodromal clinic because they think you might be about to be developing psychosis. If you've got a higher genetic predisposition, you might develop paranoia or paranoid psychosis, but it's not full-blown schizophrenia. And if you're at the highest end, you might develop schizophrenia. So it's part of a dimension like hypertension or like obesity or like anemia. It's a continuum. So now I wrote this paper that many people think schizophrenia is a progressive deteriorating disorder. I do not. I think this is the most damaging view inherited from Krepelin and kept alive by bad psychiatrists. Because if you believe that schizophrenia is a deteriorating illness, you have an excuse for your patients getting worse. If your patients get worse, I think it's your fault, because you have not, or our fault, because we have not treated them properly. And I wrote this paper, the paper earlier this year, making the point that schizophrenia should not be progressive, except if things go badly wrong. And this is with colleagues from England, but also Dr. Bora. Many of you will know Dr. Bora, who is a Turkish psychiatrist with a great knowledge of neuropsychology. And one of the things that we pointed out is in the general population, this polygenic risk score for schizophrenia. People with the high polygenic risk score for schizophrenia, the general population, have a slightly lower IQ, 95 rather than 100. But it doesn't get worse as they get older. It doesn't progress. So there is no genetic predisposition to developing a cognitive impairment and deterioration in schizophrenia. But people with schizophrenia and other psychosis are subject to numerous factors associated with cognitive impairment. Cannabis use, tobacco use, obesity, hypertension, poor diet, poverty, homelessness, anticholinergics. All of these make them more likely to have cognitive impairment. Some of them we cause, and others are a consequence of their poverty or the adversity that they encounter. There is now evidence that all people with psychiatric disorders have an increased risk of dementia, anxiety, OCD, PTSD, bipolar disorder. If you follow them up long enough, they have increased risk of dementia because of the circumstances that their illness leads them to be in not because of the illness itself. Now, environmental factors that increase the risk of schizophrenia often increase its persistence as well. Childhood physical and sexual abuse, neglect, migration, bullying, being brought up in the inner city in the north, adverse life events and stress, and particularly drug abuse. So I wanted to say a little bit about drug abuse. I know that Dost Ungar will be talking on Saturday about cannabis use, but do you see much amphetamine psychosis in Turkey? A bit? We don't see much. We see a lot of cannabis-induced psychosis. So there are now 3 meta-analyses showing cannabis use as a risk factor to psychotic disorders. Here is Dr. Vangelis Vassos still swimming about the Mediterranean. And these are all different studies of people, psychosis risk according to how much cannabis you've taken. This is one study, another study, another study. This is a meta-analysis. And if you see, here are the people who've hardly taken it, the 20% least cannabis, the 20% most cannabis, and all of these studies, the people that have taken more cannabis are more likely to develop psychosis. In this study, it was a very small effect. That's because it was Tien 1990 in the USA. Cannabis was very weak then, 3 or 4% THC. This one is South London in 2012. This is cannabis is now 16% THC. So the odds ratio is about 7. If you're a heavy user of cannabis in London, you're 7 times more likely to go psychotic. So if you were going your holidays, if you're going your holidays and you spend your life looking after psychotic people, you say, I'd like to go somewhere in Europe where I won't meet many psychotic people. I've seen enough of them. Where would you go? Would you like to come to London? You won't see many psychotic people in London. Would you rather go to Barcelona? So this is a big incidence study that we've done across 16 sites in Europe. And you can see most psychosis is in London, 61 per 100,000, next Amsterdam, and next Paris. We also looked at country areas, so country area around Cambridge, much lower. As the textbooks say, that their incidence is lower in country areas, and also in more rural Netherlands, lower, and in rural Paris, lower. But look at southern Europe. Across southern Europe, the incidence is just generally low, whether it's a city. Look, here is Barcelona, 12 per 100,000. So if you go to Barcelona, you're 5 times less likely to meet a psychotic person than if you go to London. My wife comes, as I said before, comes from Palermo. She took a big chance, but she's moved from Palermo to London. Her risk has gone up 5 times. So far, she's okay, actually. But there are these big variations. Why are there these big variations? Well, one factor is cannabis. And this is actually my wife's study. And this is relating the frequency of cannabis use with the incidence of psychosis. And so in the grey is the incidence of psychosis. We took out migrants to simplify it. Highest in London, then Amsterdam and Paris, lowest in Spain and Italy. And you can see here is the prevalence of daily cannabis use, tracking the incidence of psychosis, a correlation of 0.8. Surprisingly high. Now you might think, well, this is just a statistical association. Maybe you can't replicate it. Well, I should say that 30% of psychosis in London is due to cannabis use, heavy cannabis use, and 50% in Amsterdam. But we've looked in India and in Nigeria and in Trinidad as well. So this is the incidence in India, quite relatively low, as you can see, and this is the incidence in Nigeria, low. This is a rural area. This is Ibadan, a big city. This is Trinidad, much higher, especially in African Trinidadians. And this is the same kind of slide as you've seen before. The black is the incidence of psychosis, low in India and Nigeria, high in Trinidad. And here is the prevalence of frequent cannabis use. And you can see that the two follow one another. So the same picture, when you get high incidence, high prevalence of cannabis, particularly high potency, you get an increased incidence of psychosis. Has the incidence of psychosis always been high in London? No. This is work from Diego Quattroni and Jane Boydell. This is schizophrenia, not psychosis, so it's much narrower. And the blue is back in the 1960s. The incidence for schizophrenia was 11.2, so about a third of psychosis is schizophrenia. So it stayed pretty much the same through the 60s, began to climb through the 80s, and then climbed considerably by 2012. And this is looking through the case records of the patients, heavy use of cannabis, very unusual in these days. Now more than 50% of our patients with psychosis are using cannabis. So it seems that the reason why we have such high rates has changed. We didn't used to have them. You should have gone to London a couple of decades ago rather than going to London now if you wanted to avoid psychotic patients. So coming to an end, psychosis, a couple of slides more. Psychosis is no longer a mystery. We have a clear understanding of the risk factors. Treating positive symptoms is generally not too difficult. But we have to treat the causes of the psychosis to prevent its persistence and the development of treatment resistance, this non-dopaminergic abnormality with the hardwired delusions and hallucinations. So we have now, what should you do? In Britain, for cannabis-using psychotics, we treated their psychosis, we told them to stop using cannabis. They didn't, and they came back again. So we now have a clinic for, my wife and I have developed a clinic for cannabis users, which has had quite a lot of publicity. And this is an article in the Sunday Times last year, quoting a patient. Now with the clinic, I'm looking at life in a whole different way. Without the cannabis, my brain is starting to work again. I'm doing an apprenticeship that's changed my life. So we have to treat the causes of the psychosis, which comes back to the question the lady mentioned, what can provoke paranoia. And for example, social anxiety is a common cause of paranoia. So there's no sense just giving people an antipsychotic for their paranoia. You have to treat the social anxiety which they have. So I'm going to leave you with this slide, which is the first time I've ever shown this slide. This is I think in the future, we will not bother with discussions about schizophrenia or bipolar disorder, or schizophrenia or schizoaffective disorder or brief psychotic illness. We'll talk about a classification of psychosis depending on the etiology. And the lady mentioned that there would be steroid-induced psychosis. So there's drug-induced psychosis, stimulants, steroids, cannabis. We have mood disorders. We have rare organic conditions. We have neurodevelopmental schizophrenia. And with social adversity, psychosis, with childhood trauma, adverse life events, migration, discrimination. So I think it's better to move to this sort of model, but I'll leave that there for you to think about. Thank you very much for listening.